Hello, everybody. Good morning. Thanks for coming out to Facebook. We're going to be talking today about the role of genetics in infertility. I really want to thank Infertility Dosed for organizing this. I think oftentimes couples as well as individuals who are experiencing infertility might not have access to experts to ask their questions, and it's really helpful sometimes to have access to someone who can answer some of these questions that are extremely important while dealing with the diagnosis of infertility and planning a family. My name is Pooja Ramchandran. I'm the Director of Genetic Counseling at Map My Genome. We're a Hyderabad-based genomics testing company, and we're going to be talking about a few things related to genetics. Feel free to swing by and ask any questions that you might have. You may leave the comments down here in the comments section. And let's get started right away then. I think a good place to start is to talk about really what DNA is and what genetics is, since this is going to provide some context for some of the discussion related to infertility. Some of you might be familiar. Well, genes are those organized bits of DNA that really tell our body what they need to do. It defines how our body functions, and this is responsible for how our organs are developed, how they function, and some of those organs also include reproductive aspects of how our body functions. DNA is short for deoxyribonucleic acid. And it really is the blueprint of life. It codes for different aspects of health, and we are going to be focusing on the reproductive aspects of health. A good place to start now that we have a sense of what genetics is to discuss really what infertility is. Infertility is when couples who are planning a pregnancy are unable to achieve a pregnancy post anywhere between 6 months to a year of unprotected intercourse. And oftentimes this can be a great source of stress for the couple as well as for the family. I think it involves more important discussions about how to manage infertility. And infertility management is not just the management of the stress that is involved, but it is also important to understand the management aspects of what might be causing infertility. Historically, the diagnosis of infertility has relied on clinical investigations. These usually involve sperm analysis for men, hormonal studies for women, things like ovulation studies, ultrasounds to look at the structure of the uterus and the fallopian tubes, so on and so forth, as well as some hormone measurements of things like luteinizing hormone, which is LH, follicular stimulating hormone, which is FSH. We also, for women, also will study hormones related to thyroid as well, because we know all of these can play an important role. For a baby to happen, for conception to happen, we know that there are 4 things that are crucial. The first thing is ovulation needs to happen, which is the process of releasing an egg from an ovary. Sometimes there may be issues surrounding that. We oftentimes will notice that women might have, PCOD, or they might have what is called non-responsiveness to stimulation, that can be called premature ovarian failure or ovarian insufficiency. And oftentimes, there is intervention that is available through perhaps pumping in some more hormones. And it's important at this stage to consider what genetic causes might be involved in this first step, of what is required for the purposes of pregnancy. We know that amongst women who have premature ovarian failure, We know that one of the important causes for that could be potentially this one genetic condition called Fragile X syndrome, which is caused by changes in a very specific gene called FRAX1, which is located on the X chromosome. We know that in fact 25% of women who have a pre-mutation in this specific gene for Fragile X syndrome might actually have premature ovarian failure or ovarian insufficiency. I'm looking at a few questions. This is great. Keep your questions coming in. Excuse me, I'm also dealing with a bad throat here. I have a question here that says, when do you think is a good time to go for genetic counseling? It has been 3 years. I've been trying to conceive and all tests are normal. Doctor says it may be unexplained infertility. That's a great question. So usually, like I was saying earlier, infertility is defined as the inability to conceive after a year of unprotected intercourse with the intention of conceiving. So if it has been 3 years and if all the clinical tests are normal, it sounds like it might be the right time to come back for further investigations that are more genetic in nature. Oftentimes with causation of infertility, the purpose of trying to understand what might be causing infertility in a couple is not necessarily to blame one member of the couple or the other. This is not a good time at all to play the blame game and to blame her or to blame him for infertility. The primary purpose of identifying a cause of infertility is to identify an appropriate intervention, an appropriate strategy to manage that cause of infertility. So if it has been 3 years and if the doctors are saying that all your tests have come back normal and they're calling it unexplained infertility, it's definitely already a good time. Usually it is recommended that all couples with unexplained infertility speak to a genetic counselor to discuss the value of having genetic evaluation as the next line of investigation in addition to everything else that has apparently come back normal. I want to say that it's important to talk about experiences of infertility because infertility is not that uncommon. It is stigmatized for no reason, and this is a great opportunity to speak with me, a healthcare professional who specializes in genetics, and we know that 15% of couples who are trying to conceive will actually experience infertility. So I just want to say that I'm sorry that it's been so hard for you to conceive. 3 years is a long time, but I want to say that with unexplained infertility, it might be a good time right now to consult with a genetic counselor. If you want to set up an appointment with a genetic counselor, please feel free to reach out to Infertility Dost. It truly, I understand that they are your friends in your journey while you try to navigate this world of this new diagnosis of infertility and its management. Deshreya, thank you for your question. Is early menopause related to genetics? If so, does it flow through paternal or maternal genes? This is a really good question. Early menopause oftentimes is potentially related to hormonal issues, and oftentimes premature ovarian failure might result in what is known as early menopause. So we were just talking about this a little bit earlier on, so this is a good time to ask this specific question. We know that the Fragile X syndrome is a condition that is genetically caused by a change in this gene called FRAX1. We know that FRAX1 carriers, so women who have the pre-mutation for changes in the gene, about 25% of women who are premature, who have the pre-mutation, will end up being a pre-mutation carrier. And this is extremely important to discuss with couples, especially when the female partner when the wife is someone who's experiencing either early menopause or has premature ovarian failure or is unresponsive to ovarian stimulation. It is important because this is a condition that could potentially get passed on to the next generation. Fragile X is an X-linked condition, which means that the gene gets passed on to the X chromosome. So it flows from mom to children. And while women have 2 copies of X chromosomes, this is a great point to make at this stage. All of us have 2 copies of all of our chromosomes and 2 copies of all of our genes. So women have 2 X chromosomes, and oftentimes when a woman is a carrier for Fragile X syndrome, while one of these chromosomes might be not working like it should, the other one is working just fine, and this one compensates for this one. So oftentimes carriers of Fragile X, pre-mutations or mutations, might not necessarily typically demonstrate any symptoms, but it could get passed on from one generation to the next. In fact, pre-mutation carriers of Fragile X might actually experience what is known as anticipation, which means that the pre-mutation can get converted to a mutation. In Fragile X, what this means is there's a certain number of repeats within the gene. So genes are usually made of alphabets, A, T, G, and C. This is what our entire DNA is made of. With Fragile X, we know that CGG is a trinucleotide because it contains these 3 alphabets. These 3 letters get repeated and they form an expansion. So with Fragile X carrier women, we know that when it gets passed on from females to the next generation, there is a high chance that this expansion, this trinucleotide expansion, further gets amplified and can cause issues related to mental retardation in boys. In fact, Fragile X syndrome is one of the most commonly inherited causes of mental retardation in boys. And also sometimes with girls, we can see that depending on certain technical aspects of how the X chromosomes might work, we know that for some girls who are carriers of Fragile X mutations, so even though they have one that works fine and the other one that doesn't work fine, sometimes some carrier females can also manifest certain conditions related to Fragile X syndrome. It's a great time to speak to a genetic counselor if premature ovarian failure or ovarian insufficiency is one of the diagnoses for you that came up during your investigations. Thank you, Dave, for that question. I'm looking at the next question. Thanks, Sumita, for your question. I understand that your in-laws had type 2 diabetes, and you're mentioning now that your mother has diabetes as well, and even your husband is a diabetic. Is there any chance to get it for my baby? Should we take any extra precautions? Typically speaking, Sumita, we know that type 2 diabetes is typically an adult onset condition. It's what we call a multifactorial condition, which means that there are multiple factors involved in the manifestation of this disease. These multiple factors might certainly involve some genes that might predispose or might increase the risk or susceptibility for certain individuals to develop type 2 diabetes later in their life. But we also know that another part of these multiple factors that could result in type 2 diabetes are the environmental factors. In the genetics world, when we talk about the environment, we're not necessarily talking about the air around us, but we are talking about things that are non-genetic. For type 2 diabetes, these non-genetic factors can be things like diet and lifestyle. So usually with diabetes, we know that it's close to a 50-50. So there's a 50% genetic contribution, and there's close to a 50% environmental contribution that likely comes from choices of diet and lifestyle, cumulatively through the years. For that reason, it tends to manifest as an adult onset condition. So there is certainly a risk that the predispositions get passed on from one generation to the next, but there's a lot of things we can do to reduce the overall risk. There is genetic testing that is available, which is more predisposition testing. These are personal genomics tests that will look for changes in single alphabets within your DNA that might increase your susceptibility to diabetes. But typically, I would say that if your mom and your husband as well as your in-laws have type 2 diabetes, I would not necessarily say that it is directly going to get passed on to your baby. However, women who are diabetic, it is important to speak to your gynecologist so that your diabetes can be managed. We know that diabetic women have an increased chance of having a baby with high birth weight, and that can lead to some issues also. We know that gestational diabetes can be common sometimes, especially for women who have PCOD. Becomes important to speak with your gynecologist. If you have any specific questions related to family history and genetic testing, feel free to reach out to Infertility Dost, and they would be happy to set you up with a genetic counseling appointment. Hope that answers your question, Sumita. Hi, Janki. Thanks for your question. Good morning. It sounds like more of a comment. Not many women today know about genetics being linked to infertility. Even doctors don't talk about it. Genetic conditions are not irreversible as well. Is there something to worry about for women trying to conceive that genetics could be a cause? Can something be done about it? I think this is an excellent question, Janki. Thanks for bringing this up. And this is an important aspect about the evaluation of couples with infertility. We know that, like I was saying earlier, most of the investigations in couples that are experiencing infertility are clinical investigations that involve sperm analysis, as well as for the male partner, and hormonal and uterine and ultrasound analysis studies for the female partner. But we know that about 10% of all couples experiencing infertility can have an underlying genetic cause. It is extremely important to understand what this genetic cause might be, and it's important to identify the right genetic cause, especially because oftentimes the treatment of infertility, especially if it's unexplained infertility, revolves, using techniques of assisted reproductive technology. We know that ICSI, intracytoplasmic sperm injection, is a commonly employed ART technique in which the sperm is retrieved from the male partner and is artificially inserted into the egg that is collected from the female partner. And we know that this bypasses several natural mechanisms physiologically that the body has put into place to select against certain genetic conditions that could get passed on. So we have to think about this as natural conception. Sperm and egg getting together is a natural physiological process, and we know that when that doesn't happen, there is likely natural selection also that plays a role in preventing the fertilization of unhealthy sperm or unhealthy eggs that might lead to genetic conditions in the next generation, in the future offspring. So genetic conditions, while they may not be reversible, Janki, like you rightly say, identifying the right cause, especially a genetic cause for infertility, is extremely important for couples so that they can make the right decisions about what kind of assisted reproductive technique is appropriate for them. A good example is if someone's if both members of a couple are say carriers of cystic fibrosis, which is a known genetic condition caused by changes in the CFTR gene. This oftentimes will result in what is called non-obstructive azoospermia, which is usually secondary to congenital bilateral absence of the vas deferens. The vas deferens are these tubes that actually connect that connect the testes. These are the tubes that will transfer spermatozoa, will transfer sperm from the testes into the ejaculate of a male. And oftentimes when the vas deferens, when these two tubules are missing, even though sperm might be produced within the testes, there's no means for the sperm to come out into the ejaculate and to fertilize an egg. So oftentimes a good solution for this is TESE, which is short for testicular sperm aspiration. And what happens in that situation is that the sperm might contain some of these mutations that might cause cystic fibrosis in the next generation. Identifying either the presence or the absence of such a mutation that might result in cystic fibrosis in males, especially males that have non-obstructive azoospermia, is extremely important. In fact, it is recommended that all males with non-obstructive azoospermia speak with a genetic counselor about the role that genetics might have to play, and specifically about CFTR testing for cystic fibrosis. And this is important because even though that diagnosis is irreversible, if a male has been identified with a cystic fibrosis mutation, then it is important to also test his female partner for the presence of the same CFTR gene change that results in cystic fibrosis. This is extremely significant in couples who want to have a baby, because cystic fibrosis is a genetic condition that can get passed on from one generation to the next. And carriers typically don't manifest any symptoms. So, you know, I could be a carrier of cystic fibrosis and not know it. And you could be a carrier of cystic fibrosis and not know it. The chance that a male who has non-obstructive azoospermia actually has, the chance that a male who has obstructive azoospermia who actually has mutations in the cystic fibrosis gene is reasonably high, and it becomes important to test both partners for this apparently irreversible condition, so that prenatal diagnosis can be made offered during the pregnancy. So Janki, while this kind of a diagnosis is irreversible, it still allows us to choose prenatal diagnosis, which means during pregnancy there can be diagnostic testing to look for the specific gene change in the embryo. Another option that exists for couples who have been identified with a genetic cause would also be, especially in cases like cystic fibrosis, would also be offering them PGD, which is short for pre-implantation genetic diagnosis. So with pre-implantation genetic diagnosis, what happens is sperm and egg are actually artificially combined in a laboratory, and then they're grown to a blastocyst stage, which is a stage where the embryo is 8 cells large, and then one of those cells are tested for the gene change that is responsible for, say, cystic fibrosis in this example. And then only those embryos that don't carry the gene change are then transferred back again into the uterus of the woman, allowing these couples in which both members are carriers of a recessive genetic condition like cystic fibrosis to have the opportunity to have a child without a condition like cystic fibrosis. And this is oftentimes a useful strategy for most genetic conditions that are considered autosomal recessive, where both members of the couple might be a carrier, and then if both members are a carrier, there is a 25% chance or a 1 in 4 chance with each pregnancy or with each assisted reproductive cycle that both members pass on non-working genes to the next generation, and this next generation, the future offspring, could develop a genetic condition. Identifying a genetic cause can help couples in these positions make informed choices about how to continue their pregnancy, whether they would like the option of prenatal diagnosis to inform pregnancy management decisions, or whether they would like to consider pre-implantation genetic diagnosis, which is where we can actually choose embryos that are considered healthy, that do not have the mutation that both parents are carriers of, so that it is not passed on to the next generation. Hopefully that answers your question, Janki. Thank you so much for your question. But we were talking about the things that need to happen in order for pregnancy to be achieved. The first one is ovulation. The egg has to be produced and then has to come out of the ovary. The second step is that, the sperm needs to actually be able to reach the egg. Oftentimes we see that differences in sperm count, sperm morphology or the structure, and sperm motility, the ability of the sperm to swim, can oftentimes contribute to male factor infertility. At this point, I guess it's a nice time to talk about how the cause of infertility can be equally seen in males as well as in females. So about, if we were to make a pie chart out of all the causes related to infertility, about 1/3 of couples experiencing infertility will have male factor infertility. Another 1/3 of couples experiencing infertility will be experiencing infertility because of female factor infertility, and about exactly another 1/3 of all couples experiencing infertility will have what is known as unexplained infertility, where we're unable to identify a cause based on the clinical tests. That's an extremely appropriate time to speak to a genetic counselor to discuss further genetic analysis. And we'll talk about what kinds of genetic tests might be appropriate as the first line of genetic analysis amongst infertile couples. But I want to first quickly take this question. Hi, Nisha, thanks for your question. I have pot spine 3 years ago. I'm not sure I understand what this is. Now I'm taking treatment to conceive. Is there any chance that baby may have any problem due to pot spine, TB of spine? All right. We all learn something new every day. So pot spine, TB of the spine. Typically, from a genetic standpoint, we're not looking at tuberculosis being passed on from one generation to the next, especially if it happened 3 years ago. Tuberculosis is an extremely common infectious condition, especially in a country like India that is so densely populated. Oftentimes we know that it becomes very important to get TB treatment, and we know that the treatment, while it is long, it is a treatment course that absolutely must be completed, even though you might start to feel better much before that entire course of treatment is completed. But if you have completed your TB treatment course, and if you are now in the process of receiving treatment for conception, I want to be more reassuring and say that typically it's not something that we see being passed on from one generation to the next. So Nisha, I wouldn't be too concerned, but I would encourage you to discuss this with your OBGYN, with your obstetrician gynecologist, so that they can make sure that the TB has not caused any other issues. Because sometimes we can see that a tuberculosis infection can cause issues in the reproductive system as well, and you want to make sure that those issues are ruled out. Oftentimes, hysteroscopy, ultrasound, these kinds of techniques, imaging techniques, can be helpful in making a good assessment of really what's going on within the uterus, within the female reproductive system. So I would recommend that, Nisha, you speak to your obstetrician gynecologist to talk about the value of any imaging studies in determining the fitness of your reproductive system post your TB diagnosis and treatment. Hope that helps. Hi Swati, thanks for your question. Good morning to you too. Do infertility couple need to go for genetic defect investigation if there is no history of bad obstetric history? This is a really good question, Swati. Thanks for it. So bad obstetric history is a terminology that used to be used previously. It's now repeated. It has now been replaced by repeated pregnancy loss, which is experiencing 3 or more pregnancy losses, miscarriages. So that would be the definition of repeated pregnancy losses, also previously known as bad obstetric history. And we know that oftentimes with the repeat pregnancy losses, we know that there is a significant significant increase in the potential for having a genetic cause. We know that usually miscarriages are fairly common, unfortunately, amongst couples trying to get pregnant. In fact, the background risk for miscarriage for any couple, regardless of whether or not they have repeated pregnancy losses, is about 9 to 12%. We know that this risk for miscarriage increases over the age of 35 for the women, and we know that for women over the age of 40, the risk of miscarriages can reach as high as 40% because of the possibilities of some chromosomal abnormalities that can be seen commonly associated with advancing maternal age. But to answer your question, despite the history, despite the absence of repeated pregnancy losses, it is extremely important to go for a genetic counseling appointment to discuss genetic testing, even in the absence of repeat pregnancy losses, because oftentimes these pregnancy losses might happen at such an early stage in gestation that women might not even necessarily realize that they were pregnant. If it is an extremely early first trimester pregnancy loss, oftentimes there might be no way to even understand that it was a miscarriage. And oftentimes, women might just think that, well, their periods are just a week later than usual. It is important to talk about the most basic genetic investigation, which is called karyotyping. Now, karyotyping is a technical word for taking a picture of your chromosomes. Chromosomes are really condensed units of DNA that can be examined under a very high power microscope. These are coiled little structures. And we know that oftentimes we see these genetic changes. In fact, we see translocations fairly often. About 5% of couples who experience infertility will actually have a very specific kind of translocation, which is the part of one chromosome is moved to another part of another chromosome. We all have 46 chromosomes and they exist in pairs. So we all have 23 pairs of chromosomes. So this is, chromosome number 1, 2, 3, so on and so forth till 23 pairs are over. So till 22 pairs, in fact. And then there's women have XX and men have XY. So these 46 chromosomes totally really are important in terms of just what they represent, which is our genetic material. Usually anything extra, anything missing, anything at a different location than what it is supposed to be might have implications for the next generation. Oftentimes, some of these translocations might actually prevent a couple from even conceiving. So they might not even experience miscarriages because these translocations might result in a chromosomal imbalance that is so dramatic for the next generation that it is considered to be incompatible with life. Any extra or missing chromosomal material or genetic material is not ideal, and nature has a way of eliminating fetuses because they are incapable of developing their body organs and structurally and functionally developing into an embryo and a fetus and a baby. It truly is considered incompatible with life. For that reason, it is extremely important for all couples, whether they have repeated pregnancy loss or bad obstetric history or not, to have at least a basic karyotype, which is going to take a look at a picture of what their chromosomes look like in order to identify any extra or any translocated pieces of chromosomes that might not really affect them per se, but it could have huge implications for their chances of a successful pregnancy. How much of male infertility is genetic? This is a question that Infertility Those has posted on behalf of some of you guys. We know that for men, about 15% of male infertility might have a genetic cause. And this is especially true, if the sperm counts are less than about 10 million per ml. We know that, while doing an investigation for men who have infertility, a genetic cause is identified in about 15% of men, and this could, if I could put it into a broad range of what might be the most likely causes of male factor infertility from a genetic standpoint, we know that CFTR mutations related to cystic fibrosis that we talked about earlier is fairly common. In fact, we also see Y chromosome deletions. And the truth is that about 20% of men who have non-obstructive azoospermia will actually end up having Y chromosome deletions. And it's something that's extremely important to consider in men who have either severe or moderate oligospermia. And this is because of the implications it has for what kind of treatment through assisted reproduction might be available. We know that for men who have Y chromosome deletions, most of them will not be able to, there might not be retrievable sperm with TC, but we know that if there is a AZFC deletion, which is a specific kind of azoospermia factor deletion, then there is an 80% success rate of actually retrieving sperm through TC procedures. So to answer your question, about 15% of men who have male factor infertility will be identified to have some kind of a genetic cause. So some of these are, like I was saying, either cystic fibrosis related or Y chromosome deletions, or also we know that it could be some of these chromosomal issues, either a translocation or an extra chromosome. Sometimes it can be an extra X chromosome as opposed to just having XY. Some men can have an extra chromosome that may be silenced in them, but it could contribute significantly to the experience of infertility. So it's called 47XXY, and that can oftentimes be manifested. It can be identified, especially when a male is experiencing infertility. It can also be identified during puberty, which is when boys who have this 47XXY may fail to develop secondary sexual characteristics, which are things like growing facial hair, or cracking voices, or they might actually develop gynecomastia, which is an increase in the breast tissue. Hopefully that answers that question. Khushbu Shah, thanks for your question. What genetic factors does couple have to look in adoption? This is a really, really interesting question. I want to say that with adoption, it becomes important to make sure that, exactly like we would do for all children, newborn screening is extremely important. Newborn screening can oftentimes identify genetic conditions in children before they even manifest. In fact, a lot of times newborn screening can identify genetic conditions that can actually be treated or managed nicely either through certain kinds of medications or supplementation or even perhaps little things like dietary modification. So the genetic factors that couples considering adoption are very similar to the genetic factors that couples who have children might want to consider, is making sure that this child or this baby has newborn screening done to identify if they have any genetic conditions that might manifest later on, but can be potentially prevented by making some of these changes either through supplementation, medication, or through dietary modification. Thanks for your question, Khushbu. Priya Chakravarti, your question is, can genetic imbalance be detected before IVF? If reports are not normal, then can the session be stopped then and there? The short answer to that question is absolutely yes. So genetic imbalances can definitely be identified before IVF. In fact, it is strongly recommended that all couples undergo at least chromosomal analysis or karyotyping prior to IVF cycle in order to identify some of these imbalances that could otherwise lead to failed IVF cycles. This is extremely important because any couple that is going through an IVF cycle, this is easy to imagine that it is, going through IVF is just challenging. It is very demanding of time. It is very demanding of emotions. It is very demanding of money. It also puts a lot of stress on the couple as well as on the family, and this is, physically, mentally, emotionally, as well as financially. So when couples are considering IVF, it becomes extremely important to have this chromosomal analysis so that they can then be offered PGD, pre-implantation genetic diagnosis, so that if a chromosomal change is identified in parents, then we can look for these translocations or the result of those translocations, which is an imbalanced chromosomal arrangement in the next generation, and then we can transfer only those embryos that don't have this imbalance back into the woman's uterus, and then just keep our fingers crossed for implantation. Hopefully that answers your question. There might not be the need to stop the IVF, but if such a change has been identified in a couple, then before IVF, PGD might be extremely important. PGD anyhow involves an IVF procedure wherein sperm and egg are collected from the male as well as from the female, and multiple embryos are created in a laboratory setting, and then each of those embryos can be tested for the genetic difference, and only those embryos that don't have this genetic test can then be transferred back to the woman, and this hugely increases the success rate of IVF. And I believe if couples are investing that much time, money, emotions in a process like IVF, it might be worth your while to just do this additional layer of genetic analysis in order to maximize the chances for successful IVF treatments. Khushbu, your next question is, what are the screening tests to be done for donor eggs to avoid any genetic defects? I would say it's extremely important to have like a basic overall screening, genetic screening that involves things that are extremely common. We know that in India, beta thalassemia, alpha thalassemia are extremely common genetic conditions, but we also know that congenital adrenal hyperplasia is also significant. We also know that Some women can be carriers of, Fragile X changes in the, in the FMR1 gene. It is important to discuss with a genetic counselor what are the specific conditions that are important to screen for. But I would say that there are these basic conditions that are extremely, extremely important to screen for, and it might be worth your while to speak with a genetic counselor so that they can discuss with you the specifics of all of these conditions. But I would say thalassemia, cystic fibrosis, hemophilia, sickle cell, congenital adrenal hyperplasia. These are conditions that are definitely well worth screening donor eggs as well as donor sperm for. Joy Ganguly, thanks for your question. What kind of conditions suggest that male infertility can be genetic? That's a good question, Joy. We know that a genetic cause is oftentimes identified in about 15% of men who have male factor infertility, and especially the presence of severe or moderate oligospermia is extremely important cause for referral to genetics. Another important reason for, another important indication for referral to genetics in male infertility is also azoospermia, which is the complete absence of spermatozoa. This could reveal, either bigger changes, numerical or structural changes in the chromosomes. It could, through karyotyping, it could reveal tinier deletions on the Y chromosome that cannot be identified on a karyotype, called YQ deletions. It could also identify AZFC deletions as well. And then finally, also with obstructive azoospermia, cystic fibrosis remains a concern, and it's extremely important to look out for either obstructive azoospermia, non-obstructive azoospermia, or oligo azoospermia, or azoospermia itself. Sorry, oligospermia or azoospermia. These are good indicators for male infertility to go to speak to a genetic counselor. Welcome to the live session, Gitanjali. Swati, I see you have a question. You have a question related to karyotyping, and your question is: consider, if a couple has a karyotyping defect, either male or female, how successful are we in correcting them? This is a great question. We are born with our DNA, and our DNA is organized, structurally into chromosomes, and these chromosomal structures cannot be changed or altered in us. Usually, as adults, if we do have a chromosomal change, it is typically not one that affects us in a very big way. So we might not be able to correct these chromosomal changes in us, especially if it's a balanced translocation. It gets balanced, and we still have all the genes and all the bits of DNA typically that are required, unless the break point is in the middle of a gene, where sometimes we see that there might be the manifestation of a genetic condition. So while we cannot correct chromosomal abnormalities identified on karyotyping in couples, either male or female, we know that when they're trying to conceive, we can offer them pre-implantation genetic diagnosis to make sure that only the embryos that do not contain a chromosomal abnormality or an imbalanced chromosomal arrangement, only those embryos that have a balanced chromosomal arrangement can be transferred into the woman's uterus through an IVF-like process. So we might not be able to correct the chromosomal changes within the male or the female that is a carrier of one of these translocations, but we can definitely help them achieve a pregnancy through pre-implantation genetic diagnosis that can ensure that only those embryos that don't have an imbalanced chromosomal structure get transferred to the woman's uterus, and this greatly improves the success rate of IVF procedures. We have about 5 minutes to go, so bring on any further questions that you have. Tanu Sarkar, you have a question here. What are the genetic disorders that cause infertility in both male as well as female? This is a good question. We know that some of the disorders, like I was saying, one of the most common conditions related to infertility is cystic fibrosis. This is especially true for males who have non-obstructive, for men who have obstructive azoospermia, usually, congenital bilateral absence of the vas deferens. This leads to azoospermia because the vas deferens that transfer the sperm from the testes into the ejaculate are absent from birth. So that is one example. We also know another example might be amongst women. We might see Fragile X. So Fragile X carrier women, have an increased risk for premature ovarian failure, or for having low ovarian reserves, which oftentimes indicated as low levels of AMH, anti-Mullerian hormone, which is oftentimes part of routine clinical investigations for women. So that's a second example of a genetic condition that is related to infertility. And Fragile X is extremely significant because it can also cause mental retardation in boys in the next generation if it does get passed on from a carrier female. Another example is congenital adrenal hyperplasia. Can also oftentimes manifest as PCOD amongst women. So this is another great opportunity to speak to a genetic counselor, and this is also a great time for a referral to a genetic counselor if a woman has either PCOD or if she has premature ovarian failure or is non-responsive to ovarian stimulation. Other examples are things like Kallmann syndrome. In fact, we see Kallmann syndrome in 20% of males. It's caused by a genetic defect in the CAL1 gene, and it can oftentimes result in secondary sexual dysfunction, which is usually hypogonadotrophic hypogonadism, which is small testes. Interestingly enough, other signs related to Kallmann syndrome are actually anosmia, which is the absence of sense of smell, which seems strange, but it's a really good sign to consider speaking with a genetic counselor if you're a male and you have low sperm count and you can't smell anything, or if you have hypodontia, which is issues with the way that your teeth are formed. So these are just a few examples. There also is primary ciliary dyskinesia, also known as Cattargna syndrome, that causes defects in how the cilia are formed. And cilia are an important part of the tail of the spermatozoa and can significantly affect how the flagellum of the sperm is developed, and it can negatively impact sperm motility, consequently resulting in lowered success rates of fertility. It can also, interestingly enough, cause hearing loss. So if you see hearing loss or teeth issues or the inability to smell in men, that goes along with lowered sperm count. It's sufficient reason to ask for a referral to a genetic counselor. Once again, if you do want to speak to a genetic counselor to talk about what your specific case might have to say about your fertility, feel free to reach out to Infertility Dost, and they will definitely set you up with a genetic counselor. I'm going to take just a couple of more questions. So how much percentage does genetics cause for failure of implantation after embryo transfer? Swati, this is a really, really good question. It's hard to really tease apart the genetic causes of implantation failures. I think it makes more sense to consider a genetic cause prior to transfer, so that we can maximize the success rate of embryo transfer. We can maximize the success rate of implantation and the success rate of an IVF cycle. So that certainly could be a significant percentage related to genetics that could contribute to implantation failures, but implantation failures could also be related to the endometrial lining, things like hormonal imbalances, and we know that success rates of IVF can range anywhere from 15% to as much as 30%. Some centers will quote higher figures depending on what their success rate is, but it's important to talk about the success rate of these, IVF cycles with the clinics that you might be considering. Tanu, you have one question. I'm going to take, this might be the last question. PCOD is said to be a lifestyle disorder. How can we equate it to hereditary? Because we hear genetic diseases are hereditary. That's absolutely right. We know that PCOD is likely considered to be a lifestyle disorder, but we also know that PCOD can oftentimes manifest, in women who might actually be carriers of, congenital adrenal hyperplasia, which is 21-hydroxylase deficiency. It's a deficiency of a very specific enzyme. It's caused by a very specific gene change. In those situations, there might be a genetic cause. Otherwise, it might be modulated by environmental factors and lifestyle factors, things like stress and diet and nutrition and exercise. But overall, we do notice that PCOD can be because of a lifestyle related condition, but we know that there likely is a genetic contribution to that as well. Sometimes it's hard to tell what may really cause PCOD. It's not exactly known yet, but we know that there is a certain section of women, especially carriers of congenital adrenal hyperplasia, who might actually be at risk for having PCOD. And for that reason, all women with PCOD must also, PCOD or PCOS, might benefit from speaking with a genetic counselor to see what kind of genetic tests might be appropriate for them, especially if they have also been experiencing infertility. We're almost done here. It's about, it's a little past 11 o'clock, but I want to just summarize the things that we've talked about. Infertility is when couples are unable to conceive, a year after unprotected intercourse. We know also that about 15% of all couples who are trying to get pregnant will experience infertility. So I'm trying to say this in order to normalize the experience of infertility. There's a lot of stigma associated with infertility that must not be. And you must always feel free to reach out to either your doctor or to a genetic counselor to discuss your infertility if this is something that you are concerned about. About 10% of all couples who are experiencing infertility will be identified to have an underlying genetic cause. So for all couples who are experiencing infertility, 1 in 10 might actually have a genetic cause. So it's extremely, extremely important to seek genetic help. Reach out to a genetic counselor. You have access to infertility dose. If you ever need to set up an appointment, they will do that. Thank you for joining me on this session this morning. Hope you guys found this useful. Stay in touch. Continue to ask your questions to Infertility Dosed, and they will direct them to me. For those of you who missed it, or for those of you who are watching this video when it's not live anymore, feel free to continue to direct your questions to Infertility Dosed. Thanks for being here. Thanks for watching, and have a good weekend. Bye.